Okay, right, so now clinical trials in GIST. So Professor Robin Jones is with us now. I met Robin many years ago, but heard about his work in America first. So thankfully he's come back home to England and is now leading the Royal Marsden Institute of Cancer Research. So he's been a massive supporter of GIST Cancer UK. So thank you very much for coming, and I'll hand you over to Robin.
Thank you so much for that kind introduction, and it's really nice to be here today. Really nice to see a lot of familiar and friendly faces in the audience as well. So, thank you. That always helps. I'm just going to not use my slides at all, but I'd like to say thank you to Sharon and Zoe for the last-minute swap as well. So that's really kind, and sorry to cause a bit of hassle there. So my talk is going to be really sort of simple in a way, and I suppose that the sort of fundamental message is that there are lots of new treatments for patients with GIST, and I'm going to try and split it up into basically two main components: treatment of early disease and treatment of metastatic disease. And this sort of links in with Zoe's presentation in terms of the evolution of tumours, the complexity of tumours, and whether we should be focusing more on early stage disease, even though we've got a lot of really good options for patients with advanced disease. So this is the plan. So as I say, really simple presentation, and I've cut it a little bit short so that we have more time for discussion and questions, because I think that's much better rather than me showing about 150 slides and everybody falling asleep before lunch. So as I say, I've split it into post-operative or adjuvant clinical trials, and then clinical trials for metastatic disease. And we've got a really good evidence base in terms of the post-operative use of imatinib. There's a recent publication by the French sarcoma group of longer duration of imatinib, and we're awaiting the results of the Scandinavian sarcoma group trial of 5 years of adjuvant imatinib as well. So I think that's really important in terms of trying to treat tumours early to prevent them from developing metastatic disease and becoming really complex and heterogeneous. And then in terms of trials for metastatic disease, there are lots of interesting drugs in development, but I'm only going to focus in on a handful for the presentation. There's the PEAK trial, as was mentioned previously, which is using a new drug called Bezuclastinib in combination with sunitinib. There's also a drug called Ripretinib, which is being evaluated in a current randomized trial for patients with a specific mutational profile. There's a really exciting drug called IDRX, which there was a presentation at the American Society of Clinical Oncology meeting earlier this year with really promising results in patients who'd received a lot of prior treatments for metastatic disease. And finally, there's a drug called NB003, which is also in development for metastatic GIST. And as I say, I think the most important thing here is that we have lots of time for questions and discussion rather than me just going on and on with loads and loads of slides. So in terms of localized disease, unfortunately, despite optimal surgery, optimal resection of the tumor, about 50% of people will go on and develop recurrent or metastatic GIST. Since this publication about, 25 years ago now, there have been a number of clinical trials, firstly looking at comparing imatinib versus no imatinib, showing that 1 year of imatinib was beneficial. But there's been a trial which has established the standard of 3 years of post-operative imatinib run by the Scandinavian sarcoma group that basically offered the trial to patients with tumours that were very high risk in terms of the size of the tumour, in terms of the way that the tumour cells were dividing, and if the tumour had broken or ruptured. And this basically, this trial randomized patients to receive either 3 years or 1 year of post-operative imatinib and showed a benefit for 3 years of post-operative imatinib in terms of the time it takes for the cancer to come back, and also in terms of how long people lived for after surgery. And these are the survival curves for that trial, showing a benefit for 3 years of post-operative imatinib, and that's become the international standard for patients with tumours that have high-risk features after surgery. But over the last 10 years, the French sarcoma group have performed a trial basically allocating patients with high-risk tumours to receive either 3 years or 6 years of post-operative imatinib. They use slightly different risk criteria for recurrence than the Scandinavian trial, but they have shown a benefit for 6 years of post-operative imatinib compared to 3 years in terms of the length of time it takes for the cancer to come back. And this is the curve for so-called disease-free survival, recently published in Annals of Oncology. So there was no difference between the two arms in other factors, including the time to develop imatinib resistance, survival, adverse events, and quality of life. And I think, in a way, we need a little bit longer follow-up of this trial just to see if any differences do develop between these two arms. So this, again, is a really important trial performed by the Scandinavian sarcoma group, but various sites in the UK, Spain, and other countries participated in this trial. And this allocates patients to receive either 3 years or 5 years of post-operative imatinib. And this trial has completed recruitment, and we're expecting the results probably sometime next year. So watch this space regarding this important trial in terms of 3 versus 5 years of post-operative imatinib. So in terms of trials for metastatic disease, the context is clearly really, really important. Imatinib is a very good drug in terms of first-line treatment for metastatic disease, and other drugs have subsequently been approved since the introduction of imatinib, so sunitinib, regorafenib, more recently Ripretinib by the FDA, but unfortunately that drug's still not reimbursed in the UK as fourth-line treatment for metastatic disease, and then a drug called Ripretinib for a specific molecular subgroup of GIST that's resistant to other drugs that we use. And again, Ripretinib is still not reimbursed in the UK, so that's one of the sort of major discussion points regarding the fact that these drugs are really effective for advanced GIST, but there seems to be a lag and a delay in terms of getting reimbursement and approval in the UK. So the first drug that I'm going to discuss in terms of clinical trials for metastatic GIST is a drug called Bezuclastinib. And this is a really interesting question, because in the past we've tended to do trials of just one drug versus either placebo or a different dose of the same drug. But in a way, and again this fits in with Zoe's presentation, it probably makes sense to have a broader drug coverage to cover more mutations. And this is the rationale for the PEAK trial, in terms of a trial comparing just sunitinib alone as second-line treatment for advanced GIST, compared to sunitinib plus this newer drug called Bezuclastinib, so that they are covering different mutations, different resistance mutations. So Bezuclastinib covers resistant mutations in KIT exon 17 and 18, whereas sunitinib tends to be better for resistant mutations in KIT exons 13 and 14. So there's a real sort of logic for using this combination so that you have broader coverage in terms of the mutational profile of metastatic GIST. And this is the design of the trial. So the main entry criteria was that this is a second-line trial, so patients have all previously received imatinib. And there was initial part one to the trial that basically looked at different doses and different schedules, but the crux of this trial is that patients were either allocated to receive sunitinib or sunitinib plus bezuclastinib with progression-free survival, so that the length of time that it takes for the tumor to start progressing, to start growing again as the main endpoint of the trial. But another important aspect of this trial is looking at the side effects and the toxicity and the quality of life of the combination, because one of the reasons that we haven't done combination trials before is the risk of having more side effects and more problems in terms of the quality of life of an individual patient with combination therapy. Sunitinib, many people consider it as quite a toxic drug. In many ways, I think this combination in terms of the dose of both drugs it's been good in terms of tolerability. And I think one of the things as well is that we've become better at managing the side effects of drugs such as sunitinib and regorafenib. And that may explain some of the negative clinical trial results, that the sort of historic benchmark for these drugs in terms of their activity was a little bit lower because people were developing a lot of side effects and were stopping the treatment early. But I think we've become much, much better at managing these side effects. So just quickly regarding ripretinib, there was a second-line trial again, so for patients that had received treatment with imatinib. And this trial looked at the efficacy and the safety comparing ripretinib versus sunitinib. And this is my point regarding the management of the side effects of some of these older drugs. So in this trial, there was no difference in terms of the efficacy of ripretinib and sunitinib in the overall trial population. As you can see, those two curves are virtually on top of each other. And sunitinib in this trial did much better than everybody expected, but I think that's because we've become so much better at managing the side effects, and people can carry on sunitinib for longer rather than just stopping because of the side effects of treatment. And in terms of side effects, I think ripretinib is relatively well tolerated. Unusually compared to a lot of the other drugs that we use in GIST, it can cause hair loss and some blood value changes, but in general, it's quite a well-tolerated drug. But the important thing here is that a subgroup analysis of that trial showed a significant benefit for ripretinib in a particular molecular cohort of GIST. So in the group of patients with ctDNA KIT exon 11 and 17 and 18 mutations, patients had a much better outcome if they were treated with ripretinib rather than sunitinib. So this was using a blood test to measure the amount of circulating tumor DNA in patients' blood, and that subgroup analysis of the patients that had blood tests and had this particular mutational profile showed that ripretinib was much better than sunitinib. And that has led to another trial in this particular molecular subgroup allocating patients to either receive ripretinib or sunitinib, and that trial is recruiting right now. And the primary endpoint, the main aim of this trial is to compare the progression-free survival, so the length of time between the two drugs for the cancer to progress or to get to grow, basically. And there are other standard endpoints in terms of the safety, the quality of life, the radiological response, so the actual shrinkage of the tumours between the two arms. So I mentioned IDRX earlier on. This is currently being evaluated in an early stage clinical trial. Again, this has quite a broad range of activity against a lot of mutations. And it's currently going through it's been through the dose escalation phase, so the part of the trial that looks at different doses and sees what the side effects are and how the body metabolizes it. So it's gone through that stage and is now going on to evaluation in different lines of treatment in metastatic GIST. And there's actually a cohort for patients being treated for the first time for metastatic GIST. So as imatinib is such a good drug, previously we haven't really looked or compared drugs to imatinib, but this I think is a real opportunity in a way, and this is a message that clinical trials are good because in a way they open up a different line of treatment for individual patients. So in discussion with patients in clinic, what I usually tell them is that we need to be strategic and think about keeping as many options open as possible and using a clinical trial as one other line of treatment, and then we can fall back on the other approved drugs. And the relatively good side effect profile with this drug. I suppose as with any medication, there is a risk of diarrhea, nausea, vomiting, tiredness, etc. And really good activity. This is the presentation from the oncology meeting earlier this year in Chicago, and you can see that that the majority of patients on the trial had tumor shrinkage. So these patients had received a lot of prior lines of treatment, so this is very, very encouraging. And then finally, the last drug is NB003, and again, in a similar fashion, this drug is designed to try and cover a broad range of mutations, and is also now completed the dose escalation phase, so the part of the trial where we test different doses and see what the side effects are, and has gone into the expansion phase, so looking at specific patient groups, so patients that are receiving at second, third, fourth line, etc. And so with this drug, I'd say that the main side effects tend to be edema or swelling around the eyes, swelling in the arms and limbs, and sometimes even accumulation of fluid in the lungs. So something to sort of watch out with this drug. And Dr. Lee, earlier on this year, at the same oncology meeting in Chicago, presented the initial efficacy results. So again, a promising signal here with quite durable benefit from this drug. So I promised I'd be short and sweet, so maybe not sweet. But so in conclusion, we're awaiting the results of the 3 versus 5 year adjuvant imatinib trial. There are a number of promising agents in development for metastatic GIST, and I haven't gone through an endless exhaustive list here, but just to give you a flavor that there are a number of drugs in development. And I think the exciting thing over the next few years is that there'll be more work in terms of actually deciding which drug is the best drug for an individual patient, hopefully through using blood tests, so that we can say, well, you've got a much better chance of responding to Ripretinib, or you've got a much better chance of responding to Bezuclastinib and sunitinib. Therefore, we should use that next, rather than just saying, well, the treatment is imatinib, sunitinib, regorafenib. So I think there'll be much more emphasis on an individual's molecular profile or their tumor's profile, and more emphasis on combination therapy. And if these drugs that are in development have a really good toxicity profile, side effect profile, then it's easier to use them in combination with other drugs. And as I mentioned, clinical trial participation is really important. Not only do we get more information to help patients in the future, but it also opens up another line of treatment for an individual patient, so that we can actually fall back on the more standard drugs if the trial treatment doesn't work. And I think, all of these trials have only been possible through collaboration. Again, as Nick and Zoe have mentioned, it's absolutely critical that there's international collaboration with other centres in Europe, in the United States, in Asia, so that we can, just get more drugs approved, more drugs reimbursed for patients all over the world. So with that, I'll say thank you, and I hope everybody's still awake.